the slide over here. I have to walk over there.
Bardzo proszę. So we are changing slides using
Oh, this one.
this one,
Okay.
and it works. So
Okay.
you have two tools in one device.
Okay, that's good. That's good. Go backwards, right? Oh, which way to go backwards? Yeah, that should go backwards. Yeah.
Very good. I had a brief look.
Oh, good, good, good.
I think that we may.
Let's see.
I will be back with you just. That's the definition. No, it's that like that. And
It works.
Yeah, you can use the mouse. Yes. Okay. So no announcement. Ale nie spóźnia się. Ja myślałem, że
Ona mi wczoraj jeszcze nagrali, to powiedziała, że właśnie ja, pani profesor się nie spóźnia, dlatego jestem zdziwiona, bo ona jest na
Właśnie ostatnimi nową anegdotę, czyli słuchaj, jechałem z nim walki myślałem, że wszyscy jedziemy, no, wspólnie wszystkich przybrali, jak to też, a to jest
Czasami poziom skromna, czasami poziom skromna jest taki więcej mówiłem. I know very well. Nie wszyscy jesteście wysyceni, ale on jest taki najwyższy.
Czekam. Good afternoon. I have a great honor and pleasure to welcome you to the lecture of Professor King from Joslin Diabetes Center, Harvard University. We are extremely happy Professor agreed to give this lecture during our conference. I also welcome authorities of our university, Professor Beata Tobiasz-Adamczyk, Professor Maciej Małecki, Professor Tomasz Brzozowski. And I would like to ask Professor Maciej Małecki to say a few words of introduction.
Dear colleagues, professors, doctors, dear students, I would like to welcome our distinguished guest and lecturer, Professor George King from the Joslin Diabetes Center, Harvard Medical School, Boston, Massachusetts. Dr. King is a professor at the Harvard Medical School and director of the Joslin Diabetes Center, the world-leading institution dedicated to research and clinical care in the field of diabetes. Joslin Diabetes Center employs about 600 researchers and clinicians. Dr. King graduated from Duke University Medical School. He's associated with his current institution since 1981. Dr. King is one of the best-known researchers working in the area of basic science of diabetes. His research is focused on the mechanism by which hyperglycemia and insulin resistance are causing diabetic retinopathy, nephropathy, and cardiovascular diseases. Additionally, Dr. King and his group approached the question of diabetes complications from clinical research studies. Dr. King has published numerous papers in journals like Science, Nature, New England Journal of Medicine, and many, many others. Dr. King has recently performed intensive research on patients with type 1 diabetes who did not develop a significant retinopathy and nephropathy in spite of 50 years of diabetes or more. And he will be talking about this today. Finally, before I let Dr. King speak, it is important to let you know that he's a great friend of Poland and Poles. There were many, many fellows from our country that had the opportunity to work at the Joslin Diabetes Center, and it wouldn't have been possible without a support of the people like Professor George King. So let me ask you to applaud him very warmly from the bottom of our hearts. Let's applaud Dr. King. And to illustrate this, I prepared one old photograph. This is a photograph from mid-90s, and there are several people from our country. The most important one is Professor Andrzej Królewski, a full professor of the Harvard Medical School from Boston. Andrzej left at the beginning of 80s, and he was a fellow at the Joslin Diabetes Center. And again, it wouldn't have been possible without the support of the institution and of many friends from this institution. And there are a few more of us here. Professor Tomasz Klupa, there is also Dr. Bogdan Lipiński, and this is also myself. And I think that this was a great time to be at the Joslin Diabetes Center. You know, more than 20. I couldn't believe more than 20 years ago. And two slides, okay? We had a wonderful discussion yesterday with Professor King, with Professor Tobiasz Adamczyk, with our Dean, Professor Tomasz Grodzicki, about the epidemiology of type 1 diabetes in Poland. And to illustrate how important this problem is, look, this is the incidence rate 25 years ago. More or less 5 cases per 100,000 children and teenagers, and over 25 years we experienced a growth of 5 times. And another paper from Lancet published a couple of years ago, and we experienced the largest growth in Europe over this time. You see about annual incidence incidence rate was about 10%. So this is a very important medical problem. And to talk more about type 1 diabetes, I would like to ask here Professor George King. George, the stage is yours.
Well, thank you. Oh. Yes, thank you. Well, thank you for having me here. Certainly, it's been very exciting to visit with Professor Moeski's laboratory and department, and visit Jagiellonian University College of Medicine, and the wonderful 2 days visit Krakow. And actually, I don't know what my impression of Krakow before, but certainly it's a beautiful, beautiful city. I didn't realize there was so much history, so this is wonderful to have this opportunity. And also, it's the when I was asked to speak to the faculty, I was very calm, and this is very exciting. But when I'm told I have to speak to medical students, it actually made me very nervous. You never know what the medical student, whether they like a talk or not. So I hope you will at least learn something. It's difficult to ask medical students to enjoy anything, but hopefully you'll at least learn something. So this is a picture of Joslin Diabetes Center on one side, and the other is Boston. If you have a chance, please come visit. Joslin Diabetes Center is right in the middle of Harvard Medical School, so we're the major diabetes center for Harvard Medical School. It's very exciting for us to have so much connection to Krakow. We have Professor Moeski's in Dr. Koleski's laboratory made I think a wonderful discovery a few years back, and Jan Skupian, Dr. Skupian as well, and Thomas Krupa and Dr. Walkall. All of them, I think all of them are back in the university. Oh, there it is. Okay. So it's very nice to see our previous fellows doing so well. At the Joslin, I just want to spend a minute telling you we have any one time 110 to 130 students and fellows studying with us. They're usually there for about 3 years. And 50% of the students and fellows are actually from outside of the United States. So if you get a chance, look up our website, and hope you will visit us. So today I am going to talk about complications of diabetes, which is the why is so much interest for many countries. It's a huge problem, and about 300 to 400 million people in the world have that. Now, why does everybody are worried about diabetes? It is the leading cause of blindness in the developed nations, so including Europe, and especially in working adults. It's a increased risk of strokes and cardiovascular mortality. It is the leading cause of kidney failure in all developed nations. So it's because of the blood vessel and nerve problem, it's a leading cause of amputation for the lower limbs. It increased the heart cardiovascular risk by 2 to 3-fold. And I always bring this up, and everybody wonder why I bring this up. It's the major cause of periodontal disease. And always, when I say that, people always have a smile, but you actually don't realize, many people don't realize the major cause of loss of teeth in older adults is periodontal disease. And there's actually a direct correlation of how many teeth you have after 70 years old and how long you live. So it's a major issue, because to think about it, if you don't have teeth, your nutrition actually gets bad. And so that's a major problem. Now, I'm going to focus on vascular disease today and give you a little summary of what we think is known and what is our thinking about what is causing the complications that is changing over the last couple of years. So in diabetes, the complications are in both small blood vessels and in large blood vessels, so the arteries and the kidneys and the capillaries that we've shown here. And the pathologies are very different. And that's why it's so difficult to find a single treatment for all the blood vessel diseases. Because if you look at the artery, which is a large artery, you get atherosclerosis, and you have proliferation of smooth muscle cells. So the cell migrate and proliferate. But if you look at the capillaries, the same contractile cells, which is called pericytes, it's hard for me to point here, is that in the kidney, which is the middle blood vessel, something called the podocytes, they actually die. So this is the same type of cells, but in one organ, they die in diabetes, and in the artery, they actually proliferate. So if you have a single treatment, it's very difficult to control both processes. In the past, we focused on the risk factors. So if you look at the retinopathy, neuropathy, cardiovascular, and nephropathy or kidney disease, they are very different risk factors. For the small vessels, the hyperglycemia, elevated glucose level, is a major cause. But for the cardiovascular disease, there are many causes, and hyperglycemia is only one of probably 7 or 8 risk factors. Now, another thing that's really interesting and difficult about diabetes is, as we know that hyperglycemia causes many of the problems, but genetic and epigenetic modulators is also important, because diabetic kidney disease, only about 30 to 40% of the diabetic patients will develop kidney disease, right? They all expose to hyperglycemia, but only 30 to 40% develop them. And lastly, local responses. Local responses is very important because, as I mentioned before, the abnormality in the blood vessel in the eye and the heart are very, very different. So we know that hyperglycemia, as measured by hemoglobin A1C, HbA1c, is very important, because if you have increased hyperglycemia or high HbA1c, you have increased complications. So if you don't have high glucose level, if you don't have diabetes, you're not going to get eye disease. So we know that hyperglycemia is critical for the development of eye disease, and kidney diseases may be so. Now, in the past, we focused our attention really on the causes of how hyperglycemia causes, how is it toxic for the blood vessels. So there are many theories, as outlined here, that aldose reductase pathway, advanced glycation pathway, reactive oxygen or oxidative stress, or something called protein kinase C activation. And that leads to glucotoxic effects and cause damage to the cells. And there are, in green, they are listed some of the inhibitors or treatment has been designed over the last 40 years, perhaps to slow this process in diabetic patients. The problem with that is all these trials of drugs have been negative. So the success rate of developing a treatment for diabetic complications, especially due to high glucose levels, over the last 40 years, and 50 years now, have been zero. So a few years ago, we started to rethink this process of why our success rate is so bad. Maybe our theories are wrong. Oh, so here is the difficulty. So for example, in the retina, you have increased blood vessels, angiogenesis. But in the same patient or the same diabetic animal, you actually, in the heart, have decreased blood vessels. So if you have a treatment for the eye, if you give it systemically, you actually can cause heart attack. So it's not so much success if you can save the eye, but you die. So everybody's blind when they're dead, right? So this is the problem. How do you find a treatment? So this is our paper in 1994, where we discovered that the major reason for diabetic eye disease, severe eye disease, is because it's elevated levels of VEGF, VEGF. I'm sure you have heard about it in your preclinical years. So if that is the reason for the cause, then the treatment should be inhibitors of VEGF. But we don't want to give anti-VEGF systemically because they'll cause heart attack or leg amputations. So it's now given directly injection into the eye. So this is a data that show that if you use inhibitors of anti-VEGF, you could improve vision in diabetic patients with severe eye disease. So as of 2 years ago, that inhibitor of VEGF is now approved by the governments, many governments all over the world, as a treatment for diabetic eye disease. Now the discovery, the reason I'm mentioning this is that this discovery started with the patients, right? Remember what I said? The discovery started when we actually examined the eye, the vitreous fluid of the diabetic patient. So we are often asked, if I'm in research, what's the point getting a medical degree? Why don't you just get a PhD and you could do research better than MD, right? Because that's the focus. But it's very important for medical research that we actually learn from the patient. But this is very important that this is the only treatment that has been successful for diabetic complications. And that started, the discovery started with the tissues from the patient. And when we found out about this, we went to the culture cells. We cultured blood vessel cells from the eye. Then we showed that how important VEGF is. Then we went to the animal using inhibitors of VEGF to show that inhibitor could prevent the complications of diabetes, the eye disease. And then you went to the patient, right? Everybody got the U shape? The U shape? No? Okay. Went from patient to the lab, back to the patient, right? So that's the classic medical research. So this is a very important point. Oh, this is to show that injection after 3 years improved the. So that led to a rethinking of what's causing diabetic complications about 10 years ago. So we proposed at that time that diabetic complications is due to high glucose and elevated free fatty acids and so forth that could cause toxic materials to be formed, such as AGEs, ROS, NF-kappa B, all these inflammatory substances. But by itself is not enough. So in order to get the complications, vascular complications, the body actually has to lose its protective factors. The protective factors are like antioxidants. We're going to talk about insulin in a few minutes, but we have to discover PDGF as being a protective factor in the eye. So in diabetes, you have to lose the protective factors and then have the causal factor to be activated. So this is the theory of two double hits. It's not just a single hit, but a double hits. I won't have time today to go over into the mechanism, molecular mechanism, which we published a few years ago on this issue. What today I want to talk about is our new work. So the question is, are there endogenous protective factors against the adverse effect of diabetes? How do we know there are protective factors? I just said we postulated there are endogenous protective factors, but how do we know? How do we really know this happens? But there are clinical evidence in support of these protective factors against the development of vascular complications. One very important paper was in New England Journal from Professor Koleski, you just heard about, in the 2002. And what he showed is that if you follow 386 patients with something called microalbuminuria, so evidence of kidney disease, for 12 years, that only about 15% really develop very bad kidney disease. And most of them actually don't develop any kidney disease, may even be reversed. So clearly there's some factors in the body is protecting the progression of the kidney disease. Now, another study I want to tell you about is this is purely from clinical observation. So people with type 1 diabetes, if they live for 50 years on insulin, very unusual. This is probably only 0.5% of all type 1 diabetic patients. And we give them a medal because they certainly deserve a medal. It's not real gold. It's just it looks like gold, but many patients think it's real gold, but it's actually not gold. And but they're very proud of this, to live for 50 years. Think about what happened 50, 60, 70 years ago. Many of these patients have lived 70 to 80 years with diabetes. You don't know how difficult it is to have diabetes in the 1930s, 1940s. We had a patient who was developed diabetes in 1925. So you have to sharpen your own needle. And the needle is very big, 23 gauge. I don't know, you know how big the needles are, 23 gauge. And they have to boil their own urine to test if you're a mother with diabetes, you have 80% chance of death if you have a baby. And your baby also have 80% chance of death if you have diabetes. So it's a very, and the doctor will tell you not to get married, not to have children, and you'll have 50% chance of going blind, almost guaranteed. So for these people to live for this long without too much problem, there's something really interesting about them. So we start to study this group of patients because our theory is that if a large number of these patients don't have any eye disease or kidney diseases, they must have some basic factor in their body to protect them against these complications, because there's no way from 1925 to 1960s you could have very good glucose control. It's just almost impossible, right? So we bring them all to Joslin, 1,000 of these patients in a cohort, and they come from all over the United States. And their age is about 70 years old, 69.8. They're diagnosed around 11 years old. They're juvenile onset. On the average, they have 58 years of diabetes. They're not overweight. Their BMI is about 25, equal male, female. They're in pretty good control. The hemoglobin A1C is 7.2. They do make a little bit of C-peptide or insulin still, even after 50 years. And they have a very good lipid parameters. So this is classic type 1 clinical phenotype. Because a lot of people say, how do you know they have type 1 diabetes? But we typed them and tested them and so forth. Now, what this shows, this is an important slide. So we have studied 1,000 of these patients now. And what you see is about 43% have cardiovascular disease, 34.5% have neuropathy, 46% have proliferative retinopathy, and only 11% have any kidney diseases. So what we found is 35% of this 1,000 people don't have any significant eye or kidney diseases, even though they have high glucose levels. All right. So obviously, and a lot of people say, well, you don't really know, but these are really wonderful patients. 50% of these patients have agreed to donate their body when they die. And about 100 of them have died in the last 10 years. And that's actually a very low death rate. These are 70-year-old people. And over the last 10 years, only 100 have died. So that means only 10 die per year. So it's very low death rate. Now, if you look at it, this is a kidney pathology. So the kidney on patient 1 is 84 years. He had 84 years of diabetes, and the kidney is absolutely normal, totally normal. And the patient number 8 had 59 years of diabetes, and her kidney actually did have a lot of kidney problems. So, and the glucose control in these two patients are no different. So clearly, something is protecting patient number 1 from kidney disease. So we have 350 of these patients. And the eye disease, even better. This is a patient who 4 or 5 years ago has 74 years of type 1. He's still alive. He has now about 80 years of diabetes. And his eyes are totally normal. There's not a problem. So how come these people have such a protection? And what we have done is plotted on this graph 2 groups of people we have followed. The red group developed eye disease like other diabetic patients about 20 years. But the blue group, we followed 152 for 50 years or longer, and only 2 of these patients went on to develop any eye disease, which is really amazing because we take photo of their eyes every 2 years. And you can see that the red group goes on to develop eye disease, but the blue group just stabilizes. They develop a little bit of microaneurysm, 1 or 2, and they'll stop. So something is clearly stopping the pathology. So we think it's very important to find out what these protective factors are. And this is another way of looking at this. The first group, the blue and the white, is that they don't have any real eye disease, and the red ones do. So they went on to develop. So this is called bimodal distribution. So clearly, these 2 groups are very different, and we are in the process of finding why they are different and what are the protective factors for the eye and the kidney. And from the cardiovascular, it's also very exciting. In diabetic patients, the women, in non-diabetic patients, the women are protected from cardiovascular disease compared to the men. And in diabetic patients, the women lose all their cardiovascular protection. However, in this group of patients, the women still are protected have lower risk from cardiovascular disease compared to the men. And through a variety of epidemiology studies, we have shown that the major reason for that is the level of HDL. The women has very high levels of HDL, much higher than the normal population. And that's one reason, as shown here from analysis, that the women are protected from cardiovascular disease due to the high level of HDL. And we have identified the approximate level of HDL in the diabetic women that protecting, which in the US unit is 60 milligram per DL. So it's higher than the normal population, non-diabetic population even, but I think it's achievable by at least in type 1 diabetic patient with exercise and nutrition. So that's a very important, and that paper should come out in Diabetes Care either this month or next month. But what can you do? So we help the women, but can we do anything for the men? Well, it turned out exercise is incredibly important for the men, and you could increase or you could decrease the risk for cardiovascular disease in men if they exercise moderate to high level of exercises. And it's shown here. If you do certain type of exercise, physically active, in the male, the risk for CVD drops dramatically. So this is at least 45 minutes a day for at least 3 or 4 times a week. And this is, and you could do many different type. It doesn't have to be, running on the treadmill, as I was mentioned to Professor Morawski yesterday, that one of the most popular in our group, these are 70-year people, is dancing. They do ballroom dancing. I don't know whether y'all like ballroom dancing. It's like the waltz, forgot what those other ones are, and tango. So initially when I heard about it, I didn't think they were that physically active until I went to actually observe them. It's really a lot of activity. They do an hour, 2 hours, and people sweat, and it's really, it's actually very popular now at Harvard, MIT, ballroom dancing among the college and the medical students. Surprisingly, medical student, I don't know how they have time, because when I was a medical student, we never had time for dancing, but now they do. They don't go to classes anymore, I noticed. Well, I won't go there. But anyway, so we have actually made a serious attempt to look at what are the protective factors. I don't have time to discuss in detail, but we used proteomic analysis, genetic analysis, genomic analysis of their eyes, their kidneys, their heart as well. And I will share with you that we have identified by proteomic analysis, we think at least 9 proteins in the eye that we think is going to be protective. And we have studied one of them, and we'll be announcing that protein this summer at the American Diabetes Association, what that protective factor is. And we also have studied the kidney, but the two are very, very different. And the eye, all the protective factors do not have any antioxidant or anti-inflammatory actions. But in the kidney, however, 4 out of 15 proteins do have antioxidant or anti-inflammatory patterns, and no common protective factor in the eye and the kidney. So clearly, the organs are very, very different. But let me finish up in the last part because my first part of the talk is mainly clinical. But these days, you could do clinical study, but it's very important to actually have mechanisms. If you don't have mechanism to explain the phenomenon, the credibility of your hypothesis is really not accepted, right? We can't tell people this happens, magically happens. So it's really important to have mechanism. So let me give you a little mechanism about one protective factor. It's very well known, insulin. Insulin, we think, is a protective factor for diabetic complications. And I'm going to talk about cardiovascular disease. So in cardiovascular disease, diabetic patients have many pathologies, including main ones atherosclerosis, restenosis, cardiomyopathy, poor collateral vessel formation, and fibrosis. Well, I'm not going to go through all of them, but I'll give you a little bit of our new data and finding in atherosclerosis and endothelial dysfunction. So, as I mentioned before, cardiovascular disease has many risk factors in diabetic patients. One of the main ones that's unusual for diabetic patients or metabolic syndrome patients is hyperinsulinemia or insulin resistance. So, this has been an argument going on since 1960s. Are insulin's effect on cardiovascular tissues anti or pro-atherogenic? When I was young, as a fellow in the 1970s and 80s, this was already a huge argument. And hopefully we could settle that pretty soon because we could now give mechanistic data. Now, I know that many medical students start to fall asleep when we show a molecular signaling. Signaling is very important. Believe me, signaling is very important because signaling is where all the new drugs for cancer therapy are coming from. And this is also will be in diabetes in the future. And you have to use the right drug. Otherwise, you're going to expose patients to risk that's not necessary. So insulin action in the blood vessel on endothelial cells is at least twofold. And as we proposed here, that you have anti-atherogenic action, it's in blue, going through something called RS-PI3 kinase pathway. But insulin can also cause and have pro-atherosclerotic actions going through the MAP kinase pathway. So 2 pathways, that's all you have to remember, is that one side is anti-atherogenic, the other side is pro-atherogenic. So if you lose the blue side, you're going to have increased atherosclerosis. If you increase the red side, you can have more atherosclerosis, okay? This is what we proposed in 1999. And then multiple people have shown that insulin could actually increase blood flow. So that's good, right? That's activating eNOS and so forth. We also reported that insulin have antioxidant effect by a mechanism activating an enzyme called heme oxygenase 1. I won't have time to discuss. Is the antioxidant enzyme. So this is sort of theory of selective insulin resistance in blood vessels as causing accelerated atherosclerosis. That's now being accepted by almost every laboratory on this topic. So again, insulin have anti-atherosclerotic actions through RS1 and AKT that can decrease VCAM, increase HO1, activating eNOS, nitric oxide, and other things. So, but if you have diabetes or obesity, you have inflammatory cytokines that will activate something called PKC, protein kinase C, and that could actually inhibit this pathway, the blue pathway. So it's called selective insulin resistance because it accentuates the red pathway. So it's selectively inhibiting the anti-atherogenic pathway. And there's been hundreds of papers showing that. And I just want to give you quick evidence to support that, to give you an idea how you want to prove a theory, right? So first of all, we look at the tissue. This is from the heart, blood vessels from human, animal. So if you can find this common throughout the different species, then the theories become stronger. So here you show that phospho-AKT, PAKT is inhibited, but ERK is not in the heart, in the myocardium. Selective insulin system, one pathway is inhibited. And then to really prove this in multiple ways, Christian Rasmussen from University of Copenhagen is in our laboratory. He's an assistant professor now. Knocked out the insulin receptor only in the blood vessel, only in the endothelium, okay? And using multiple breeding and molecular techniques. This just making the mice alone took 3 years. So another year to do the characterization. So to give you a little idea, I'm going to show slides in the next 2 minutes, but it took him 5 years to really finish this project. So what he shows is when you eliminate insulin receptor from the endothelium, you have increase in atherosclerosis, right? See that? Venerco ApoE mice. It's a double knockout mice. And this double knockout mice have a lot more atherosclerosis than the control. So if you don't have insulin receptor in the endothelium, you have increased atherosclerosis. So insulin is actually very important. I won't have time to talk about it, but again, we actually have identified how PKC causes selective insulin, which serine molecule on the signaling peptide is causing the inhibition. Because if you want to make a drug to inhibit PKC, you want to make sure you're hitting the right target, right? So I don't have time to do that. But Dr. Chen Li in the laboratory then overexpressed something called PKC beta only in the endothelium, because we propose that's causing the selective insulin resistance, right? And when that happened, the mouse developed a lot more atherosclerosis. So we're one step at a time to prove the theory. Everybody got that? Remember the theory? Insulin resistance, PKC, to selective insulin resistance. Here we go. So first we knock out insulin receptor. We show PKC when this activated will cause more atherosclerosis. So in the next step then, to really prove this hypothesis, we say, okay, we have to enhance this pathway to actually decrease atherosclerosis. So this paper should be coming out soon. This actually have not been published. So what Min Park in the laboratory have done is he have overexpressed RS1 in the background of a ApoE mice and says, okay, if the theory is to say this will cause if we think this is causing atherosclerosis, if we improve insulin action here, make insulin more active here, then you should decrease atherosclerosis. So that's what he did. And again, that took another 3 years. And what he showed is this is show that we overexpress RS1 in these mice and enhance insulin actions in the endothelium. And what he showed is that, very excitingly, that in these mice, which is diabetic and high level of insulin, these mice actually have a lot lower atherosclerosis. So this is really the first proven that if you increase insulin action only in the blood vessel, you could actually decrease atherosclerosis. So this is really a summary that we think selective insulin resistance is the major reason for atherosclerosis in diabetes. We think we increase insulin pathway. In that way, you can actually decrease atherosclerosis. Now, if you're a pharmacologist, especially a protein pharmacologist, you're going to be very excited. Why is that? Because since the discovery of insulin in 1921, all we have done is make insulin work faster, work slower, long-acting insulin, short-acting insulin. But what this data tell you is you can actually design your insulin to actually decrease atherosclerosis. That's going to be incredibly exciting if you could design insulin to decrease atherosclerosis and not only control your glucose, but you could help your eyes, kidney, and atherosclerosis in the same insulin. That's why it's so exciting. So the new theory, let me just finish up here then, is that high glucose not only causes complex toxic materials, but also inhibits the endogenous protective factors. And when you have both of them, that's when you develop complications in your organs. So, we have many people in the laboratory. Dr. Hillary Keenan is the epidemiologist, helped me with she's a co-PI on our MEDALIST study. We have ophthalmologist, Jennifer Sun. I didn't have time to go into kidney issues, Dr. Robert Statton, and certainly our laboratory, many people who have, many fellows, wonderful fellow who's worked very hard, and certainly funding. This is not a cheap study. This study, I don't know the Polish money, but it costs us about $1.5 million a year to do this study. I think it's about by 4, it's about 6 million Polish currency per year just to do the study, not even this, the other stuff. So it's our funders, wonderful, has been very supportive, and certainly patients. These are wonderful patients. If you do clinical studies, every time we want something from these patients, 80 to 90% of the patients will volunteer to help. So I think that's very high for clinical studies. So thank you again for having me here.
Professor King, dear George, thanks a lot for this fascinating lecture. Thank you very much, not only for showing the specific data on diabetes, but also for providing us a general overview what the contemporary research is about, medical research, from the clinic to the basic science and back to the clinic. Thanks a lot for using the language that was well understood, not only for the faculty, but also for the medical students. I'm sure you see they are smiling and waving their heads. And
I don't see too much waving.
well, but a lot of smile.
A lot of smile.
Yeah. And let me ask you a question. We are putting a lot of emphasis on differential diagnosis of diabetes. As you know, we are very much involved in monogenic diabetes research. I know that you perform new generation sequencing in this cohort. So were there many individuals misdiagnosed with type 1 diabetes?
Yeah, so about 5% of the these type 1, long-term type 1 diabetic patients have non-autoimmune diabetes. So clearly, well, 5% is not huge, but it's actually a lot of people, because if you're talking about in the US, we have 2 million type 1 diabetic patients. So 5% could easily 100,000 people. So it is actually very important. There's a lot of thought that every patient, if you don't have auto antibodies, should be sequenced.
I think that this paper is open for discussion now. Do you have any questions to Professor King? I strongly encourage to do so. George, would you agree with me that currently it's not so difficult to achieve reasonable glycemic control, and all those patients with type 1 diabetes receive, many, I would say, medications protective from the point of view of cardiovascular disease, like statins, aspirin, from their early age. And don't you think that pretty soon we'll see that the expected life duration would equalize between type 1 diabetes patients and the general?
Well, I think we'll be closer, but I don't think, unfortunately, it's almost impossible to get complete glucose control, which in the type 1, to prevent all these complications, you pretty much have to get below hemoglobin A1C below 7%, because the curve takes off after that. So these patients in general is about 7.2. So I think it's going to be still somewhat difficult. But in type 2 patients, it's very difficult because, as you know, that the cardiovascular disease of type 2 patients starts before they develop diabetes. So even if you cure type 2 diabetes and all the hemoglobin A1C is below 6.5, they still have increased risk for a cardiovascular disease. So that's important to realize.
Thanks a lot. Any questions to Professor King? If this is not the case, this is not the end of the session. Dear Professor King, we have a habit that at the end of every visit, in the framework of our visiting professorship program, we would like to somehow commemorate the visit of our special guest, like yourself, with a special certificate. This is a part of our Omicron project. So please take this certificate from me, and to remind you your visit in Krakow. And thanks a lot for visiting.
Thank you. Thank you. Thank you.
We are really grateful for your inspiring lecture. And with this little gift, we would like to thank you very much for it.
Thank you. Thank you.
Thank you.